can actually hear the background music of the YouTube channel. Are you on the YouTube channel as well?
No, I didn't open that section.
可是我的头好像太低了，我觉得。老师，你不能调整啊，那就按按钮。对呀，老师，你跟他们试试看。Hear me?
Jerome was able to join fine.
What? Jerome cannot join us.
I didn't wear my tie though. I should go up and get my tie. Hi Danny, how are you? Let me see how to work this silly program. Can you hear me?
Yes.
I can be heard. Okay.
Jerome, are you in California?
Yes.
Already? Okay. Yes, super. I was worried about you because it would have been 1 a.m. your time in Switzerland.
Yeah, I know. I'm lucky. It's only, it's really nice time for me. It's 5 o'clock.
Well, you and Vero.
活动的研讨会。那这一次我们国际研讨会邀请到世界各国重磅级的国际学者来跟我们分享 ICF 的运用。那我们赶快进入到这精彩的演讲。那首先邀请我们台湾 ICF 研究协会理事长刘灿宏理事长来致开幕词。
参加我们这个 ICF 的年会，同时这也是我们第6次的世界的 ICF 的这个国际研讨会哈。那首先我要感谢我们的协办单位，包括中华民国伤残重建协会、台湾职业重建专业协会、中华民国特殊教育协会，还有中华民国启智协会哈。那今年的主题呢是身心障碍呢，在过去这10年间的转变哈。那回首这过去这10年路哈，我想整个 ICF 呢，在过去，假如说从101年开始算起的话，今年已经迈入第10年哈，也就是说我们的心智已经上路10年。那如果我们再把时间再往前挪移，再从民国96年通过身心障碍者权益保障法的时候算到现在，那已经有15年的时间。在这过去这10年或是15年当中，我们整个 ICF 的这个学会呢，投入很大的一个心力哈，在协助我们的政府，那在逐步的调整，那滚动式的修正，那也预计呢，在很快的下一个月，就是我们的111年的1月呢，我们就推动我们第10版的上路哈。我想这是一个在过去很不容易的一个历史哈。那也目前在全世界大概我们台湾的 ICF 应该是属于 pioneer 的地步哈，大概也只有我们台湾把 ICF 全面的实施在这个整个这个身心障碍的制度，我想这是一个世界上的一个奇迹。那我们今年呢，也因为这样子呢，我们特别把我们过去长期合作的这些国际的伙伴呢，我们再把它邀请过来。那今年呢，我们这个大会呢，邀请了3位的这个讲者。这3位呢，几乎呢，我们本来都是希望能够邀请他们过来哈。那这几位呢，几乎就是办义务的来我们台湾哈，不过因为今年疫情的关系，他们没有办法过来。那3位都说，只要一旦解封、一旦开放，他们一定是第一个冲过来哈。我想他们对我们台湾的这个友好，我就可以看得出来。那第一位呢，我们会邀请的是 Verónica Schiariti， 那她是我们的加拿大的一个学者哈。那她跟我们分享的是，在这个世界这样子的变动之下，那新的一个儿童的这个 ICF 的评估工具是什么？我想这是 Verónica， 她会今天第一个 section 会跟我们分享的部分哈。那第2位我们这个邀请的是 Reuben Escorpizo， 那这也是一个美国的一个学者。那长期 Reuben 呢，以前他每次来讲的都是主要是跟工作相关的。我们刚刚说这个工作的部分呢，我们已经听了很多了哈。那今年呢，我们就邀请他呢，以这个生物、心理、社会的层次，就 biopsychosocial 的层次呢，来跟我们分享一下。就是以一个这样子的一个模式之下，我们用这个模式来看一个人的一个身心状况。那可不可以用这个模式呢，来看到一个人的转衔？就是以这个 CP 小朋友，就脑性麻痹的小朋友为例，他从青少年转衔到成人这个过程当中，我们如何从他的生物、心理、社会方面去整个从 biopsychosocial 方面去评估他的一个发展？我想这是一个很新的观念哈。这个是第2位我们邀请的这个 Reuben 的部分。那第3位呢，我们邀请到我们一个更老的朋友，他的确是年纪有点大了哈，但是他是目前应该可以说是 ICF 的一个主要的一个发起人之一哈。那最近他们又新创了一个期刊，这个期刊也是我想未来会是很重要的期刊，叫做 Frontiers in Rehabilitation Science， 就是复健的这个前端啊。那这个 Jerome Bickenbach 呢，他目前是在瑞士哈。那他的这个期刊里面，他的题目就是 ICF and Human Functioning， 那翻成中文就是 ICF 跟这个人类功能的一个发展。那这是一个现在很新兴的一个题目。那这个部分呢，就是我们以前在人类的描述，大概我们描述的都是跟疾病的关系。但是比较少人去描述说，我们这个人类呢，它是如果在功能上方面，比如说经历了疾病、经历了人的发展之后呢，如何用这一个 functioning 来去描述一个人的功能？我想今天这个题目呢都非常的精彩哈。那这3位呢，保证是国际上的大师哈。我想在国际上的一些，不管是 ICF 的大会啦，或者甚至在 WHO 都可以看到他们3个人的身影哈。 那今天呢，我们也特别感谢这个廖华芳老师、赖普志老师，还有季文宙老师来担任我们的今天的座长。那同时，我们也邀请这个赖普志老师还有潘依林老师担任我们这个现场的翻译哈。这些老师的这个投入呢，我想让这个年会呢能够更加的顺利哈。那所以我们预祝呢今天这个大会能够顺利成功。那各位会员先进呢能够收获满满，身体健康，阖家平安。谢谢。
相信大家对这3位国外学者已经有初步的认识了。那接下来赶快进入我们精彩的 session。首先呢，邀请廖华芳老师来替我们做第一场研讨会的开幕导引。
Good morning. My name is Hua Fang Liao, and I'm the chair of the.
Hello, everyone.
I'm the chair of the academic committee of the Taiwan Society of ICF. It is my great pleasure and honor to moderate the fourth speech of this virtual conference. And before the beginning, I have a few housekeeping notes. Today's session is being recorded to be available for viewing post-conference. If you have any questions for the presenters, please use the chat box of WebEx for presenters to answer after the end of each presentation. Each topic will have about 40 minutes pre-recorded presentation and 20 minutes Q&A. After the presentation, we have two live translators, Ms. Pan and Dr. Lai will then read questions out for the presenter to answer. You can speak in Chinese or in English. Now, let's please welcome our fourth presenter, Dr. Verónica Schiariti. Dr. Schiariti is currently an adjunct associate professor at the Division of Medical Science at the University of Victoria in British Columbia, Canada. She is a physician scientist. Her work bridges clinical research and international child health, especially ICF and children with disability. Her topic is pediatric ICF-based tools in a changing world. Please welcome. Yeah, I think they have some technical problem now. Okay.
Hello, everyone. My name is Verónica Schiariti. It's a pleasure to join the 6th International ICF Conference organized by Taiwan. The title of my presentation is Pediatric ICF-based Tools in a Changing World. It's always a pleasure to collaborate with colleagues in Taiwan. So let's get started. I am joining you from the west coast of Canada in the province of British Columbia. You are seeing a picture of the university campus on Vancouver Island. I have no conflicts of interest to disclose. I am a member of the American Academy of Cerebral Palsy and Developmental Medicine. I recently joined the board of directors. I am a founding member of the Latin America Academy of Child Development and Disability, and my role is to connect the Latin American colleagues to the rest of the academies in the world and to facilitate access to knowledge and based on evidence-based and ICF projects. I am also a consultant for UNICEF in Latin America. We're working on creating care pathways guided by the ICF for children with developmental disabilities aged 0 to 6. And as you might know, I was the leader of the development of the ICF courses for children and youth with cerebral palsy. Taiwan was part of that project as well, and these are open access tools. The objectives of these ICF-based tools in pediatric context, to introduce and update applications of the ICF Quartet for CP. There are some news related to that, and to update on new ICF-based tools for children with autism, and some global initiatives related to the ICF in pediatric context. So let's try to cover objective number 1. You are quite familiar with the model, but I usually start my presentations reviewing the model and highlighting why it's so important having this conference and keep learning about the ICF. You know that the key concept is functioning, and this is a result of a dynamic interaction between body structures and body functions, activities and participations, which are domains so important in pediatrics. And that functioning relates with the dynamic interactions, again, with contextual factors, in this case, environmental factors and personal factors. We're living a pandemic, a global pandemic, and environmental factors have changed so much, and they impact a lot in daily functioning. So we need to be aware of that. Another important thing is that the ICF incorporates concepts and principles that are highlighted in the UN Convention of the Rights of People with Disabilities and the Convention on the Rights of the Child. So just to highlight some of the concepts that are really linked to the ICF, the human rights of boys and girls with or without disabilities. We know that children have the right to access information, and in this era of a pandemic, it is very important. They have the right to express their opinions, to access health services. They have the right to education, to recreation, that means playing, and to social inclusion. Again, because of COVID-19, there have been different situations where the rights of children with disabilities have not been exercised. And early on in the pandemic, I published this editorial in the Developmental Medicine and Child Neurology, and the title was The Human Rights of Children with Disabilities During Health Emergencies, the Challenge of COVID-19. And this was a call for paying attention and advocate for children's rights during a pandemic. The editorial has been very important, and the message very important around the world. And the editorial has been translated into 7 different languages, including traditional Chinese. And so I invite you to check the content. But working with the ICF, for me, it's been very important to really learn how to advocate for rights, even in situations that are beyond our clinical practice or our research projects. Another key role of the ICF is as a communication tool. And this is more important every day, how we communicate, how do we really emphasize the opinions of children with disabilities and their families, and how we use a universal languages between the entire team and the families. What is the challenge? I think like the audience is very familiar with this, the manual or the length of the categories and the complexity of using the content of the ICF in daily practice is still a big challenge. So we need ICF-based tools to facilitate this. And this takes us to objective number 2, and to talk about the ICF courses and an update, because I think you know the beginning of the ICF courses and the process. Why we needed and why we took on developing the ICF courses for cerebral palsy. We knew that we wanted to use the ICF model. We wanted to really embrace the biopsychosocial model, but still it was a struggle to apply that in clinical practice and in research. So that's why we thought it was crucial. As you know, there are many classification systems for CP, but not a universal language. So we took this project in 2008, and it took us 5 years to really get it completed, and we published this in 2014. You can access the publication. We created 5 different courses and 1 comprehensive and 4 brief courses, and people have been using them since the publication. Important messages is that the ICF courses are very useful for tracking and following the developmental trajectories of children with cerebral palsy. This was missing until we published this, and so we're quite proud that we can follow all the trajectory of these children. And of course, they can be used in different settings, and again, the context is very important. And so this can be used at home, at school, and in the community. Since the publications, there have been different ways of applying the ICF courses, and I am just showing one from a Latin American country. They created an intake form, and they have one section, the top section, dedicated to the perspective of the child. So they ask key questions about what is important for them, and then the bottom part of the form has the courses, the categories of the ICF courses. This has been instrumental to facilitate family-centered care in different rehab centers. There have been many examples of the implementation of the ICF courses in different countries, and we published some examples in 2018. So I'm going to talk about some of those. So the paper summarizes the experience in different countries, in Brazil, in Russia, in Malawi, and in Poland. Overall, based on the reporting of data and feedback from professionals from those countries, the most user-friendly and feasible course was a common brief ICF course. And that was not a surprise, because this is like 25, this is the shortest version, the 25 ICF categories, and representing all the components of the ICF. But I think people need a brief tool to apply that in clinical practice. They use it with multiple applications as a guiding framework, as a communication tool, as I mentioned before, as a functional classification tool, and I'm going to show you an example, and as a method of comparing health and functional information. So if you see the application of the ICF courses are exactly the same as the proposed application of the entire classification. So this is an example from Russia. What they did was they identify evaluation tools to really apply and evaluate the areas of the ICF courses. Once they did that, and they have like a national consensus process, they created, they built a profile of functioning of children with cerebral palsy. And you are seeing different profiles of functioning based on the GMFCF classification. On the left is like the 0 to 1, 2, 3. And on the right, the 4 and 5. So you see more compromise of or restrictions in activity and participation as the kids have a greater impact in body function. So this is an example of Poland, and there's a huge rehab center in the area of Zamość in Poland. And what they did is like try to compare the services and the structure of the entire rehab center, and they map that to the ICF. And it was really a nice exercise to see that they were covering all the components of the ICF, and they were really working together and having an excellent teamwork and creating individualized, integrated rehab, education, and social interventions. So this was really like a quality improvement process that they did and figured out if there were some gaps in services and what they can improve. Overall, the impact on outcomes, clinical practice, and policy making, there was a positive change in disability approach. Once you start learning about the ICF, you start changing your belief and your attitudes towards disability. And that was across these countries. The approach changed from impaired base to a functional base. There was a really an emphasis on participation as main outcome in goal setting, and inform social policies and promote equality in different countries. So the outcome number 3, we're going to spend more time on this one. Then there's many things to talk about new tools or new initiatives guided by the ICF. One of the studies that this was a collaboration with a group in Sweden. As you might know, there are different ICF courses for different conditions like cerebral palsy, autism, and attention deficit disorder and hyperactivity. We were challenged at that time about the specificity of the content of the ICF courses for childhood onset disabilities. I think at that time it was around 2018 that people thought that there would be a lot of overlap and we didn't need different tools for pediatric conditions. So we took on this study to compare the content of the courses, of all the courses existing for childhood onset disabilities, and we show that the tools have unique functional information, as well as unique role of environmental factors influencing functioning and disability. This is one of the figures included in the paper, and the paper is open access, so you can also read the entire paper. So what we are showing here is the content, the number of categories representing the different ICF components. As you see, B, body functions, D, activity and participation, E, environmental factors, and S, body structures. And you'll see how these ICF courses differ in terms of representation of the ICF components. Most of the ICF courses represent activity and participation and environmental factors. So that's really great to see that like a huge representation of those components. But you can see in different colors that the role of environmental factors is different in each one of the ICF components. So the content of each one differ based on the categorical or diagnostic criteria. Another one of the tools that this was published in this year, 2021, and this was an initiative in Argentina, in Latin America. What they did is try to create a cultural sensitive tool based on the ICF courses for autism. You might know that the ICF courses for autism, the ones that have been published and created by the group in Sweden, they are quite lengthy as well. The comprehensive ICF course has almost 111 categories, which still is a challenge in clinical practice. So I'm showing, again, the paper is open access, so you can go and check the entire paper. But this group did a multi-step methodology, and what they tried to do is try to identify which are the most relevant categories for a Latin American context. So they did an item reduction, and they then process and would identify tools, measures that can really measure the categories included in this new ICF-based tool. They call it TEA or TIA, Si Funciona, and TEA is the abbreviation of autism in Latin America. So it was a new tool with a new name, and they created a checklist that contains 32 ICF categories, which is very, very useful in clinical practice. They are doing, they completed at that time a pilot in 100 patients, and I think I have a picture of that. Again, what you're seeing here is a profile of functioning of children with autism in Argentina. This is the first time that you have an illustration of the profile of functioning of children with autism in Latin America. And on the left, you have the children 0 to 6, and on the right, 6 to 16. And one of the key messages that they highlight is the role of environmental factors and how they can really identify which are the barriers that the kids have for participating and for communicating better. So on the right, you might identify the first category is communication tools. And for the group 6 to 16, it was a barrier. So it's important that based on the barriers that you identify, you can plan interventions, and they are working on that. Global initiatives, and again, I want to bring back the context of COVID-19. I think that we have been working on this abilities-oriented approach guided by the ICF, and again, across the lifespan. And it's nice to see that in this conference, you're going to talk about this lifespan approach. And you are seeing one example of an accessible care pregnancy clinic in Ontario, Canada, which I'm really proud that Canada has such a program, and it's a very successful clinic here. We need to work, once you work on ICF and projects like this, you need to build connections. And in this changing world, because of COVID-19, we've been very connected with experts and colleagues around the world. So I'm going to show you some examples. Again, one project is linked to the other, and I think for me, the ICF brought me to my abilities first. This is another paper that was published last year, and hopefully you can access. It's a short paper that has animations explaining what my abilities first is. It's an initiative using ICF-based concepts and rights-based approach. And there has been multiple campaigns using my abilities first. It's important because what we are asking is to change attitudes and to really ask the children and young adults to describe themselves. And we want to celebrate abilities first and not only limitations. And so last year in June, the European Academy of Childhood Disability organized a campaign using my abilities first, and we have beautiful videos from around the world participating in the campaign. Then the Mexican Academy of Cerebral Palsy replicated the campaign, and recently the Latin America Academy of Child Development and Disability just finished the campaign. And if you're interested, you can access some of the videos. They are all open access and they are available in YouTube. Of course, I want to mention that there's a My Abilities First team in Taiwan, and I always celebrate achievements in Taiwan because you are quite organized and you're an example for the rest of the world in ICF-based data and projects related to the ICF. So the ICF-based team, or the My Abilities First, they did some cultural adaptations and some activities encouraging children and families to take this approach, describing themselves and creating like an abilities identification card. So if you are an individual with a disability, you might want to create your identification card so people will know you using exactly your words or what you want or you decide them to know about you. This is a really nice way to complement the information that we usually collect in healthcare systems or in education, that unfortunately is really based on limitations or negative language. So the group in Taiwan, they organized a workshop. They did educational sessions, and they already had collaborations and support from the Department of Education, some government agencies, and the School of Physical Therapy. So again, an example of a successful take on a project. What are the secrets of a successful partnership? Like, we are all collaborating with different groups around the world. I think we need to have a common goal and hope to achieve a positive change in things that we want a successful change. Lessons learned, this is ongoing, is key to involve children, youth, and their families. This project has been implemented in different countries, and we're learning as we go. Like, the children have more suggestions, and we're learning as you see the kids, will create their own identification card, and most of them want an electronic one because they are like experts on technology. We need support and local networks, and they are essential to take on new projects. Advocacy for rights, and I think in the context, again, of a pandemic, it is crucial. The communities, I think, are ready for a change, so we need to really use this moment to achieve this change. Again, in the context of COVID-19, we have been very, very busy. I was invited to be part of the COVID-19 task force. It was organized by the International Alliance of Academies of Childhood Disability. And you might know that, again, we use the frameworks, the ICF and the human rights, the UN Conventions on the Rights of a Child as frameworks. And the task force organized 3 working subgroups. And I was leader of the Global COVID-19 Childhood Disability Data Coordination. We're still working on the final report, and hopefully, we can share the results with all of you soon. There were 3 different subgroups, one dedicated to surveys, that was the one that I was leading. Then one group dedicated to resources, and they were trying to identify resources that will help families transition the COVID-19 pandemic, some help about remote support, and successful ideas. And I'm proud to say that one of the successful ideas that was identified was my abilities first. Then the third group was listening and sharing subgroups. And what they organized for was a series of webinars and trying to share information with the rest of the world. And last year, the global event on CP, World CP Day, they were part of that session as well. And I know that Taiwan was part of the global event in 2021. One of the papers that was published in February, and I published this with Professor Robin McWilliam, that you in Taiwan, you are very familiar with the routine-based model that he has created. And this paper was a perspective paper, and again, an open access paper, describing that innovative strategies, and we were promoting collaborative, empathic teleintervention for children with disabilities during the pandemic. And it was a mix of using the principles of the routine-based model in combination with my abilities first. One of the projects that I managed to accomplish during the pandemic was the publication of this book, Early Child Development from Measurement to Optimal Functioning and Evidence-Based Policy. And this started as a special issue, and then due to the impact of the special issue, I was invited to organize this as an electronic ebook, and so you can access again an open access ebook that was published 2 months ago. And I always highlight that the organization of the content was based on the ICF and again human rights, and the content audience, you might see there are 16 chapters, and we have groups from and colleagues from WHO, colleagues from the World Bank contributed to this book. So I like to invite you. There are colleagues from Taiwan as well as co-author or leading authors of some of the papers. Okay, we're wrapping up. There were many, to evaluate the impact, I think it's, there have been many initiatives and projects, and it's always essential, the knowledge translation, conferences like this, to keep sharing the message. You might know that there's an ICF educational e-tool or a web page with clinical studies that you can go and teach your students or your trainees, or like refresh your knowledge about the ICF based on real case scenarios. And you'll see the kids here, Ethan, Lola, Megan, Lucas, and Matthew. And there are many papers that I can share with you. But I think we keep learning and we keep growing about, how to make this knowledge accessible and rapid for implementation. Again, one of the initiatives has been based on education and active education. This is an example of an ICF e-course in a pediatric context that I created this material in 2016, and it's been growing again, as I've been mentioning, until I think up to 2 months ago, there were more than 1,200 participants from 14 countries that had taken the course, and these are some of the satisfaction or like the survey that we take after the course. The majority of people recommend the e-course to their colleagues and trainees, and people people feel that they are ready for implementation after using the e-course, which is really a really nice thing to see. There are challenges in pediatric context. There are no universal access to ICF education. So I think that if people don't know about how to use it, they are not going to use it. And so I think that we need to keep pushing and showing that it's very important to have formal education related to how to adopt and use the ICF. Currently, learning about the ICF depends on the interest of the professionals. There is no top-down mandate to invest in ICF education. And I hope that conferences like this will make a change and people will hear that we really need a structure, a formal structure of education. There is still no clear understanding of the benefits of adopting the ICF in organizations, services, or health and education systems. So I feel that I have a very important role of keep pushing this agenda of making the ICF or the access to ICF concepts available to all. So in summary, the implications for everyday practice, there are many, but I just want to highlight some. It is crucial to know the diagnosis. So still we need to work on early diagnosis in pediatric context. The commitment of the structure of the impact of body structures and body functions is important. So we need to be experts on that. It doesn't mean that we need to leave all the knowledge that we have. We just need to complement this with a functioning-based approach. And I think that that's what the families and the children are telling us. The ICF and ICF-based tools like the courses are useful to understand all the factors that interact to achieve the optimal functioning of the child. After all, daily functioning is what families and children value the most. And we have done many qualitative studies showing this. So we have evidence to support this statement. I mentioned different references. Most of them are open access. And if you don't find that, you can check on ResearchGate. I think I have posted most of the papers there, or you can contact me and I can share more information with you. Once again, thank you very much for the opportunity to share this information with you. And I congratulate you for keep learning and participating in this event. Thanks a lot.
Thanks for Dr. Schiariti's excellent presentation. And if all the audience have any question, please raise your hand and identify yourself. And or you can also add your questions in the chat box, and we will read out for Dr. Veronica to answer. And here are some questions in the chat box. The first one, as a knowledge translator of ICF, what are the facilitators and the barriers of applying ICF framework for serving children with disabilities and their families? And Ms. Pan will translate it in Chinese, and then Veronica, could you answer it? Okay.
这个问题的中文翻译是：身为一位 ICF 的知识转译者，在运用 ICF 服务身障儿童与家庭时，您认为会有哪些促进因素与障碍因素呢
？Yes, Veronica, do you like to
Okay.
answer it?
Hi again. So we are learning from professionals and families. First, everybody embrace, like everybody celebrate the model. So that's not a barrier. I think people are willing to adopt this. most of the barriers are the time, like people feel that it's time consuming or there are not enough resources, like people don't have access to electronic records or a platform that will facilitate the adoption of the ICF. So I think that's one of the main things. But still, I think that our role is to encourage them to learn and try to use the ICF there are different applications. You don't need to be an expert in coding about qualifiers, but I feel rewarded when they just use the entire approach, that they start writing their reports or like planning their assessments using all the components or all the model of the ICF, like not just focusing on impairments or on the impact on body functions or body structures. So it's little by little, and I think we're learning from each other. So I always encourage people to report back and describe barriers and how they solve them. So that's the only way that we keep learning and improving.
老师的回答是，他建议专业跟家庭呢，他们都有机会可以来了解 ICF。那他认为说，其实大部分的人都是很愿意了解 ICF 的架构跟 ICF 的概念。那不过比较常碰到的情况会是时间跟资源的不足例如有一些地方他们可能在运用电子资源不是那么方便。那他的建议是说，不见得一开始就要从编码系统，也许可以先从 ICF 主要的架构跟构念所以他鼓励大家可以先从，譬如说报告的撰写或者是先了解，先从这个一般性的报告，或者是从一般性的叙述来了解这些个案的功能然后也可以利用 ICF 的一些架构跟概念来运用在整个计划的服务上，然后也可以从不同的人们或不同的国家国际之间互相的学习，来增进我们对 ICF 的运用。
Okay, thanks. And the second question is, could you talk more about the top-down implementation of ICF? Translation, please.
那第二个问题是想要请
Sorry, I cannot hear that.
就是您刚在演讲中有谈到所谓的由上而下的这个实践那请问您认为由上而下的对 ICF 的实践是什么呢
Can you understand the question?
I didn't hear the question,
Speak
Lily.
again, Pan. Can you not hear?
Can you hear us?
Can you hear us?
Can you repeat the question?
The question is, could you talk more about top-down implementation of ICF?
So, ways of implementation.
The top-down approach, top-down implementation in your presentation, in your slide. I think
So what I mean by the top-down approach is that the entire organization needs to be aligned behind this ICF approach. What I see in different centers is that professionals are willing to learn and apply a tool, but they don't have support from the administrations or like the leaders or those in leadership positions in their organizations. So what we are trying to do is like organize educational courses, but at the university level, and the universities are connected with different institutions. I'll stop there so they can translate.
Okay.
老师的回答是说，这个由上而下的这个实施其实是讲的是整个的组织或整个的这个大的架构呢，需要有一个整体的共识跟实践那就他的经验里，专业人员其实都是很愿意了解 ICF， 也很愿意执行那但是 主管的机关哈，或者是一些中央的组织啦哈，或者是在行政的层面，是不是也能够有共识一起来运用？
So I can tell you about one example in Latin America. In 2000 last year, they did a postgraduate course, ICF course, and so that was the first time that people will have like recognition, like a certificate at the university level about this knowledge, and that's empowering. That then you can, bring that back to your institution.
例子是在去年拉丁美洲，他们在大学里推了一个 ICF 的认证的课程，让经过这些认证课程的专业人士可以把这些知识带回到他们工作的单位来推行。
I think we have time only for one question. Is there anyone want to raise any question? Okay. Actually, I have one question. It's about the ICF qualifier rating. Among different professionals, how we can get the inter-rater reliability about the ICF qualifier for each item of the ICF call set. How to do it?
Yeah, so that's been a challenge, I think, across the world. And the only solution is to have clear guidelines. The example that I mentioned in Uruguay that UNICEF is supporting is creating protocols about exactly how you rate and how you translate the clinical information or the standardized tools into the qualifiers. And there's a group of interdisciplinary professionals working on that. So that's the only way, like you need to have clear guidelines.
Thank you. I think, sorry, Chinese.
老师刚刚的问题是说，有关于 ICF 编码的这个限定值的这个信度哈。那Professor Veronica 的回答是说，主要的解决的方式还是要有一个很清楚的给分的指引哈。例如说，在 UNICEF 里面，他们有一个例子，就是他们会有比较清楚的指引，就是怎么样把临床上的一些资讯哈，或者是临床上的一些资料哈，哪些资料会连接到哪一个限定值。那如果有经过这样子的过程的时候，应该在给限定值的时候会达到一个比较好的信度。
Thank you. Yeah, I think the time is up, and we thank Dr. Veronica and all the participants to join us. If you have additional questions for Dr. Veronica, you can ask them in the chat box, and we will pass all the message to her later. And let's move to the next topic. I hand over to the next moderator, Dr. Fuji Lai. Please.
that my friend, Professor Reuben Escorpizo, long time no see. How have you been? My name is Fuji Lai. I'm from the College of Nursing, Taipei Medical University. So it's my honor to be the moderator for Professor Reuben. So we have been knowing each other for years. So Dr. Reuben, because the time is so precious, so I won't spend too much time for introducing him. I think you will get to know him from his speech. So I just want to mention that Dr. Reuben has developed the Work Rehabilitation Questionnaire, which is WORQ. And this questionnaire is very useful in rehabilitation settings that we measure their capability to return to work. And it has been translated into multiple languages around the world. And I am very sure that Taiwan also has translated this. So today is our honor to have the opportunity to welcome Professor Reuben to give us his work based on the ICF and his major study on the return to work and those questionnaire, how he developed those into the ICF in this decade. Welcome, Professor Reuben.
Hello, everyone. My name is Reuben Escorpizo, and I am a professor of rehabilitation and movement science at the University of Vermont in Burlington, Vermont, the United States. First, I would like to thank the organizers of this conference for continuing to pursue and promote active efforts to using the ICF in research and clinical practice. I am very delighted to give you this talk, which will be looking at the importance of biopsychosocial constructs in outcome measures for adolescents and young adults with cerebral palsy transitioning into adulthood. This was a collaboration with multiple people named on this slide, and I would like to recognize their contribution to this important project. So I would like for everyone to imagine a young adult with cerebral palsy and also has mild intellectual disability. And this person graduated from high school recently and was offered a job as a clerk at a grocery store, and at the same time taking courses and classes at the university in the evening. So this young adult is experiencing transitions, right, from being a teenager now, or quite recently, to being an independent young adult, and then later on as an adult. There are notable challenges in any transition let alone for a person with cerebral palsy is much more can be much more challenging. The challenges include difficulty with integrating into society and the need to feel empowered as well as independent adults. As healthcare providers, we need to have a closer look at their functioning during this transition period so we are able to better understand their functioning as a whole. A real quick definition here of cerebral palsy. It is a non-progressive a person's physical and mental functioning. It is the most common motor disorder of childhood, with 2 babies being diagnosed with cerebral palsy out of every 1,000 live births. as what I've said, children with cerebral palsy can be affected in terms of their physical function, especially that will impact their developmental milestones, such as being able to walk, for example, or being able to perform their activities of daily living. Cerebral palsy can also cause mental dysfunction that can impact a person's speech and a person's cognition. It is important for us to recognize that cerebral palsy is a lifelong condition, which means that we need to be able to track functioning and milestones, developmental milestones from birth until the very end. So that process is not linear. It is very dynamic and has multiple transitions throughout. Which gets us to this concept of transitional healthcare, and specifically the term transition to adult care, which is defined as the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. So many things are happening during this transitional time that may complicate the transition of a person with cerebral palsy from, say, one care to another, or one healthcare provider to another. Some barriers to this transition have been identified, such as the need for additional time and support, the inadequate physical access to health facilities, and of course the unmet equipment needs. As you all know, as a child develops and grows, and if they're using assistive device or appliance or equipment, those things will also need to grow with the child. And so that is a major consideration in the development process. The psychosocial makeup of a person is critical during this transition period. We have the mnemonic heads. So these are factors that we need to take into account in terms of the psychosocial makeup of the child. That would be your home environment, education, employment, even the aspect of eating, activities or hobbies, drugs, sexuality, suicide, and depression and safety are all important aspects that become more and more critical during transition to adult care. Time and time again, we need a biopsychosocial approach to healthcare, right? Because of, the ICF's ability to integrate the biological and psychological and social factors that may influence health and health-related outcomes. It is important that during any transition, people with cerebral palsy are supported with their healthcare needs. A person's biopsychosocial well-being can be assessed using patient-reported outcome measures. And such patient-reported outcome measures can assess long-term outcomes and in terms of their physical health, such as pain or loss of strength, and also the psychosocial health across the lifespan, such as isolation, social isolation, and anxiety, for example. Patient-reported outcome measures should also ideally include the environment upon which the functioning can be influenced. If you can see these three circles here, it's just giving us an example of what aspects in the biology that we're looking at. We're talking about physical health. We're talking about genetic vulnerabilities, if any, or the drug effects. The psychological aspects may be including coping skills or social skills and family relationships and how they can impact the psychological makeup of the person, self-esteem and mental health. And then here, the social domains, aspects such as peers, social interaction with family and family relationships. Because the ICF is a model that can provide a comprehensive information on disability and functioning, we can document the needs of the person or of the child, identify the interventions that correspond to the person's needs, and the rehabilitation process that will need to be implemented and designed and monitored so that the child or the person will benefit from the entire situation. To demonstrate the practicality of the ICF course sets have been developed. There are several ICF course sets that are available, and one of which is intended for people with cerebral palsy. This particular course set inspires our current efforts to identify the need so we can improve and promote efficient and effective delivery of care. By using a common understanding and language to describe a person's functioning, we should be able to do just that. The ICF course set for cerebral palsy is intended to provide the domains of functioning, regardless of the type of cerebral palsy, regardless of the level of functioning of the person, and a way to ensure that personal characteristics and barriers or facilitators in the environment are also considered, especially given the ever-changing environment of a child. The ICF course sets for children and youth with cerebral palsy is available in three specific age groups. So the first age group that you see here is those less than 6 years old. The next age group is those between 6 to less than 14 years old. And then the last age here is 14 to 18 years old. And this is the one category that would be included in the transitional ages as they transition to adulthood. Liao and her colleagues validated the ICF course set for cerebral palsy in Taiwan. This was recently published in 2020. And what they found to be top predictors for school participation are basic communication. They also identified informal social relationships, school education, social play, and formal relationships. On the other hand, the ICF course set for adults with cerebral palsy, Lim Sackle and colleagues found in their expert survey that the most frequently mentioned relevant categories in this population were the design, construction, and building products and technology of buildings for public use, as well as the design, construction, and building products and technology of buildings for private use. And they also found pain as a frequently mentioned aspect of functioning in adults with cerebral palsy. Now, when adults with cerebral palsy were asked in a study by Noten and colleagues, they found, and this was just published in 2021 this year, that the most frequently mentioned aspects for adults with cerebral palsy are the 6: emotional function, pain, muscle tone, family support, products and technology, and health services. The ICF categories can be linked to existing outcome measures used in cerebral palsy, either in children and youth or in adults. These outcome measures are key to making the ICF more practical in daily clinical or research routine. These are good measures to have. They're unique, though, to their specific applied setting and to the specific population that it was developed for. Our question then becomes, what are the issues that we should consider for children and youth who are transitioning into young adulthood and adulthood? Should the outcome measures used be the same during this transition? Right? There's a lot of things that's happening during this time that is developmental in nature. So is the functioning profile expected to change during this transition? Are the outcome measures designed to capture this developmental change in functioning? The environments may change, and so does the interaction with other people and society at large. So that is the gap that we are very interested in. Which then leads us to the purpose of our project, which is to determine, identify, explore what biopsychosocial constructs in outcome measures are being used to capture functioning and disability for children or teenagers with cerebral palsy who are transitioning into young adulthood and adulthood. To accomplish this, we have 3 aims. Our first aim is to identify what outcome measures are used in transitional age studies by performing a systematic literature review. Our second aim was to identify then the biopsychosocial constructs within those outcome measures and link them to the ICF and eventually the ICF core sets. Last is to examine the similarities and differences in functioning domains during the transitional ages. And this is what we would consider as the transitional ages, which is between 14 and 26 years old. So 18 years old is usually the start of what we would define as adult in a lot of countries, if not all countries. And then before that, we have the last age group that are, between 14 and 18 years old. So given the fact that transition happens for a good number of years, we would rather be inclusive and broad in terms of our age categorization. And so that's why we came up with transitional age being defined as between 14 and 26 years old. In order for us to do this, we started a systematic search for transitional studies, transitional age studies. And we looked at this 5 databases. One is CINAHL, the other one is Ovid Medline. We also look at PsycInfo. For the outcome measure that we find, we will then subject each outcome measure to a separate search on the HAPPY website. And then for the final studies that we find, we will then subject it to a Web of Science search as well as hand searching search. hand search. We did not put any limitations in terms of language, and we also did not limit studies to a particular year. And this is again to be as inclusive and as comprehensive as possible. These are our inclusion and exclusion criteria. We have our inclusion criteria. There's 5 of them that include studies that assess participants with cerebral palsy. They have to have participants that were between 14 and 26 years old, which is our transitional age. They have to have included transition into adult care. They have to have patient outcomes that primarily focus on biopsychosocial aspects. We also consider empirical studies, such as cross-sectional or longitudinal studies, and also included systematic reviews or meta-analyses if there's any. Our inclusion criteria are 3. The first is we are not including any editorial writing. We are not including any discussion paper or perspective paper. And we are also not looking at studies that look at disorders other than cerebral palsy. This is the step-by-step process. After we did the systematic search in multiple databases, we before that we do adhere with the PRISMA guidelines. PRISMA stands for Preferred Reporting Items for Systematic Reviews and Meta-Analysis, and we specifically used the extension scoping. So we use the PRISMA scoping guidelines in this case. We had 2 phases of review that's being done by 2 independent reviewers. We have first the title and abstract screening, and then the articles that made it past that screening will be subjected to a full text review, and then any full text article that is excluded, the reason for which will have to be documented, and that's part of the PRISMA guideline. Any disagreement between the reviewers, either at the title abstract screen or at the full text screen, will be resolved through a discussion between the 2 reviewers. And if the disagreement remains, then a 3rd person is consulted. For each of the study that made it, we will be extracting a lot of information. So the first is study characteristics. So we will extract the author names, the year of publication, the country of the primary author, the type of study, the setting, which could be inpatient, outpatient, etc., the purpose of this study, and the outcome measures that they used. We will also look at and extract population characteristics, such as number of participants, what's their age, what's their education, what's their socioeconomic status, what's their race, sex or gender, the type of cerebral palsy, and the level of disability if and when provided. And finally, we will also extract the outcome measure or outcome measures that we use for each study. And then we will identify from those outcome measures items and concepts for each of the items that the questionnaire or the measure has. What we will do is that those concepts will be linked to the best fitting ICF category, and then those ICF categories will then be compared with the existing course set for children and youth with cerebral palsy and the ICF course set for adults with cerebral palsy. At the end, we will be able to generate what we would call a heat map, where you have in the first column here all the ICF categories that were identified, all those outcome measures. and then cross-link it to whether or not they are similar to the course set for children and youth and or the course set for adults. That will give us an indication of the content of the different outcome measures in relation to those two ICF course sets. Now remember that these outcome measures were used in transitional studies. And this is what I've alluded to earlier. We will be generating a heat mapping which will provide the content of the outcome measures that are used during transitional ages. So at this time, I will not be able to present the full and final result of our study, but fortunately, I can share some preliminary results with you all. After doing our search, we found 103 studies from CINAHL, Ovid Medline, and PsycInfo. From those 103 studies, 74 were excluded based on the title and abstract screening. From the 74, we have identified 29 studies and reviewed them for full text review. After that full text screen, we came up with 11 articles or 11 studies that met all of our inclusion and exclusion criteria. From those 11 articles, we initially found 26 outcome measures that were used, which later on we realized because of one duplicate, the outcome measures that we have to date is a total of 25 outcome measures. For each of those 11 articles, we'll be subjecting them, or we did subject them to hand searching and a Web of Science search, which yielded us 51 additional articles. So what still needs to be done is to review the 51 articles and subject it to the same title, abstract screening, and full text screening. But at this moment, we have 11 studies totaling 25 outcome measures. So this is 26 minus 1 because 1 is a duplicate. So we have 25 outcome measures. This is just a word cloud of the different outcome measures, the 25 outcome measures that we found. And I hope that some of these look familiar to you. You may have already used some of them in your practice or in your research. For example, we have the NOVAC Social Support Scale Questionnaire. We have the Craig Inventory of Environmental Hospital Factors. We have the Self-Efficacy Scale. We have the Self-Weighted Health. We have also found the Health Utility Index Mark III. We have the Assessment of Quality of Life, the Rotterdam Transition Profile, SF36 Assessment of Life Habits, the Canadian Occupational Performance Measure, the WHO Quality of Life Questionnaire. We have the Severity Impairment Questionnaire. We have the Traditional Readiness Assessment Questionnaire, the Manual Ability Classification System, etc. So this is just to give you an overview of the different outcome measures that we found. And again, the next step would be to look at every item of this questionnaire and to be able to link it to the ICF. So what we think at this time, and again, this dilemma that we have is again answering this question of whether or not the outcome measures that are used for children and youth are the same or may be different from the outcome measures for cerebral palsy adult version. We think that the outcome measures during this transition will assess similar aspects that are important to both populations. Our contention, though, in this study is that we think that transitional life areas, so what we would call transitional life areas, and what are those? Those refer to higher education, going to college or university, community participation, including leisure and sports. Social networking is big, probably the biggest transitional life area. And employment, some, if you graduate from high school, it is possible that you don't go to college, you go directly to being employed. And we feel that these transitional life areas are going to be deficient in those outcome measures that were used in the transitional, during transition age or transitional age studies, what we call it. That's what we think, and we're going to find it out when we have mapped all the outcome measures to the ICF. And I have brought this up earlier during my talk is, there are things that is so big for transitional care, like the home environment, again, education and employment, and even the aspect, again, of eating, activities such as hobbies, drugs is an important conversation to be had in this period, sexuality, suicide and depression, and safety. These are important issues that we need to be looking at when we look at this transitional period. We believe the transition is universal. Everyone goes through a transition as part of their development in life. And because of this universality of transition, we think that we can apply general principles that we will learn from this project in cerebral palsy to other populations such as autism spectrum disorder and attention deficit hyperactivity disorder. There's one transition though. So we go through life and we encounter multiple transitions. And this transition project that we're working on right now is just one of the many. The other transition period that we are also interested in looking at, not for this project, but maybe in a subsequent project, is the working age to retirement. We know that after people retire, a lot of them, or a good number of them, still continue to work. And that's when transition becomes a little bit blurry in that case, because, they don't really retire and not work, but for various reasons, they continue to work. So that is another transition there. Again, the overall notion here is that transition is universal and it comes in multiple stages. So then the question becomes, do we have the need to identify or even explore transitional domains of functioning? Are there aspects of functioning that we need to capture, that we need to be sure that we're capturing during these transitional stages? Is it employment? Is it education? Is it home environment? Is it sexuality, etc., etc.? That's going to be a question that I'm going to leave everyone as a food for thought, or I would say question for thought, I guess, to provoke your thoughts. And on that note, I would like to again thank the organizers of the conference for this wonderful invitation and to have been given another opportunity to pursue dialogue with people who are vested in practice and research of the ICF, and I would dare say particularly in the area of transitional ages. I thank you all for your time, and I would very much welcome any discussion on this topic. Thank you very much.
I will translate for them. So the first question is from our audience. They describe that how do clinicians identify many majors which belong to ICF? For example, some items describe some description looks like they might fit the component of activity and participation. However, some fit body function, so they might be overlap among those four items. So can you tell us how clinicians identify those majors, or in another term, how we differentiate that? So this is the first question that they would like Reuben to answer. So I will translate into the Mandarin. 我们的听众有说我们的临床的照顾者，他们如何去区辨在 ICF 4个大的项目，在台湾目前 ICF 4个大项目里面的活动、结构、参与，还有我们的身体功能。那这4者之间，尤其是这个活动跟参与，还有身体功能，好像有些时候会有一点不是很清楚能够分辨，所以他想要请 Reuben 呢，在这个部分呢，再帮我们做进一步的理清。So Reuben, it's your time to answer the question that our audience asked you.
Everyone hear me?
Yes, we can hear you now.
I suppose. Yeah. Thank you very much for the help, for the question. So this is a very fundamental question, isn't it? There's the ICF is quite clear on how it defines, the physiological function of the body as body function, and then activities and participation is, what we do, the tasks that we do, and our involvement in the community and society, with the family, with the household, etc. So the body function to me is more body. It is body. So activities and participation, something has to do with, with the outside. Body function such as, for example, lifting, range of motion, joint range of motion, for example, your elbow flexion, for example, that would be body function. So it's a function that's innate to the body, and then being able to flex your elbow. But if you're doing it in the context of something like drinking or eating or something, because you are eating and you need to bend your elbow, then that becomes activity and participation. Activity or participation if you want to go out and party, or things like that. So it's very much driven by this day-to-day life that we do. It is a fundamental question, I think. I think it's not necessarily unique to my topic, but it's something that we all encounter as ICF learners and experts, and the overlap between the two. There is no really overlap, and per definition, there's no overlap. I think it's just a matter of clearly defining the construct of function that you're trying to measure, if it is at the body function level versus it's at the activity and participation levels. So that is my short answer to that question. I think it's something that we need to go back and review and carefully look at, how the ICF defines each of those components and how does it apply. And then we can we would realize that there should be no overlap between the two. There is an interaction and relationship between the two, but technically there should be no overlap as long as you have a clear definition of what you're trying to assess. Does that answer the question?
Thanks, Reuben. I will translate your answer to them. 所以Reuben 教授是说啊，我们可能要再回头去看 ICF 里面对于我们的身体功能，还有你的社会参与，他们彼此之间它有很清楚的定义。所以他举一个例子啊，比方说，当我们讲到身体功能的时候，是举个例子好了。假设你的身体能够把这个手臂举起来，还有你的肌力，还有你的活动的范围，这是属于你的身体功能。可是这个功能呢，我们又过渡到从你的能力到你能够执行的活动，它又是另外一个连结。比方说，假设你要去参加一个 party 好了，那这个 party 呢，你要去，你会喝东西，你会喝饮料，你要移动，你要跟人家交谈，所以这个事实上是牵扯到你的身体功能，能够把杯子举起来，能够喝水，能够跟别人交谈，所以它是从我们的身体的功能又进阶到你的这个功能，它所能执行的这些活动。那这些活动呢，就会影响到你对参加这些 party 它的这个参与。所以彼此之间他们是有相关联的，所以他最后还是建议说，你还是得要回到我们在 ICF 里面，他对于这些身体功能，还有你的社会参与，他们彼此之间有非常清楚的定义。但是你把这个定义之间呢，他们还是有连结性，所以这个连结性呢，就可以来回答您刚刚所提出来这个问题。不过他有说，虽然这个问题跟他刚刚所讲的那个题目没有太大的相关联性，但是他还是给你这样的建议啊，也希望说这个Reuben教授所给你的这个回答呢，有解除你刚刚心里面的疑惑。All right, so Reuben, here's the 2 more questions. So the second question will be, could you please describe more about the heat map that you just described, so such as the content and how to use the information in the heat map? 所以我们来宾问的问题就是说，他想请Reuben教授多描述一下他刚刚在这个演讲里面所讲到那个 heat map， 就是我们讲这个加热地图啊。那他想要多了解一下这内容，那我们如何使用在这个 heat map 里面的讯息呢？再连接到他刚刚所讲的，在我们工作从青少年过渡到成年这个部分。Okay, now is your time to answer the question, Reuben.
Oh, sorry, I just muted myself. Good question. It is heat map is nothing really new. It is only a fancy term for content analysis, really, but putting it in a context of if I were a clinician or if I were a researcher trying to think of ways of identifying variables to measure, then I would like to have an idea of what the contents are of the different outcome measures or questionnaires for those folks that are transitioning from, adolescent to young adults or adulthood. It is a way for me to, in a figure, graphically describe, well, what questionnaires actually contain the transitional domains of functioning, like, for example, employment, higher education, social networking, things that are relevant to somebody who is an adolescent transitioning to young adulthood. So it is a way for just assessing those questionnaires and see if the measure as a healthcare provider that you're using for somebody who's transitioning from their pediatrician to now become their general practitioner, for example, or a primary care person other than their pediatrician, are you measuring the same thing, or are you measuring the things that you should be measuring in the context of cerebral palsy? Now, let me tell you that the content analyses, I think in my mind, we have looked at the literature on this, and this is something that's not out there necessarily. So a lot of people experience that they get lost on the radar. They don't get, once you transition from seeing your pediatrician who's using a certain outcome measure to assess your disability, and now suddenly you have become an adult or young adult, and now another person uses a different measure, and they're not necessarily capturing the things that matter to you as you transition from those two age groups. So what the content, what the heat mapping is telling us, how valid the contents are of these questionnaires in terms of transitional domains of functioning, and whether or not we can improve upon them to make sure that we capture those transitional domains once they hop over to become young adults. This is true for healthy or normal population. I'm gonna put it in air quotes there, but you know, this gap is more profound in people with cerebral palsy, and this is again something that is very concerning.
OK， so 让我来简短翻译一下鲁本刚刚所说的。鲁本是说，我们这个 heat map， 假设我们把它中文翻成热区地图好了。那这热区地图，它事实上它是一个比较概念化的，那提供我们在比方说我们对于脑性麻痹的这个孩童，他从青少年过渡到成人这个过渡期间，你可能儿科的医生或是复健科复健师或是复健科医生，他们所看的对同样一个人，他们所看的重点可能不一样。所以这个 heat map 主要是帮大家更聚焦在我们所要共同着重的点，即便你的分析的专业，或是你在这个从青少年过渡到成人的过程中，我们可能有各自的专业所评估的东西不一样。可是当评估的东西不一样的时候，如果你没有这个 heat map 来 guide 大家可能有些时候会迷失在你自己的专业里面。所以这个 heat map 协助我们各个不同专业的人，在同样提供这个青少年从青少年转型到成人的过程中，我们不会迷失了以这个案为中心，因为各自有各自的评估的点跟各自照顾的重点。所以它主要是讲的是这个，所以这个利用这个 heat map 让所有的人在对这个脑麻的青少年过渡到成人当中，它在功能的部分还有功能如何转型到我们后面它的这个过渡到成人之后它的功能的转变，那主要是用这个 heat map 呢来 guide 大家。Thanks. So that would be the final question for Reuben. So do you think it's possible to examine current environmental support in transition with ICF? 所以我们的来宾所问的问题，想问Reuben说，你觉得这有可能说我们借由检视现今的这个在 ICF 里面的环境的支持，然后来转型到我们这个从青少年过渡到成人这个期间嘛？ Okay, time for you to answer that question, Reuben.
Yes, no, thank you for the question. I think that my short answer to this question is yes, absolutely. I think that it's very much possible to look at the environment in terms of support and relationship, if you will, with those the people that are transitioning in terms of their age, chronological age, and developmental age, if you will. And that is crucial, again, very crucial in this transitional age group. And that's why we cannot emphasize more the importance of, you know, workplace environment. You know, for somebody who is a high school graduate transitioning to work and having their first work experience, and how that work and workplace environment plays. Is it able to capitalize and take advantage of the potential and abilities of that young kid to be able to do what he's supposed to be doing at work? Or for somebody, an environmental factor in school. Do we have the proper environment in school in terms of appliances or equipment, or the right table, or the right pacing by the instructors or the professors, their peers, the building, for example, is major for somebody who's now, you know, who has probably started in their high school, they just have this one-story building, and now they have to navigate around thousands of students in a college or university, and having to go to the 10th floor to go to his or her class. So the environment is quite big. And then you have the people side of the environment, the peers. Everyone here have been teenagers before, and you know how much peer pressure there is. And if you're surrounded by your peers that are not so supportive, or you could be surrounded by peers who are supportive, that can break or make a situation. Because, and you know, you have these family situations, right? Your friends, family. I mean, you have conflicts with family, and it, you know, you have sometimes deteriorating support and relationship from your family as a teenager. Again, we've all been teenagers, and as you can imagine how chaotic sometimes those teenager years can be. And that is quite pivotal because now we're dealing with the environment, but we're also dealing with, you know, what I can do as a person with cerebral palsy given my disability and how the environment interacts with my disability. Is it enabling me to do things now, or it can go the other way around and you have a negative, you know, a barrier in the environment that can also affect negatively your functioning as a child transitioning into young adulthood with cerebral palsy.
好，thanks for your answer。所以我来翻译一下 Reuben 刚刚所提的哈。所以 Reuben 举一个例子，比方说，在我们从青少年过渡到成人，那当然他这时候他的环境呢的因子的支持呢的考量，你就要考虑到年龄这件事情。所以比方说假设这个青少年他在学校里面打工好了，所以他的打工的工作环境对他来讲的意义是什么？那你同时要考虑到年龄，所以这个年龄层他们所需要这个工作的环境是什么？另外一个是在这个青少年的年龄层里面呢，他们的社会环境的部分，尤其是同侪的压力，所以同侪的压力事实上也会成为一个环境支持我们需要考量的一个很重要的因素。那当然，它除了硬体的这个环境因素以外，同侪压力，另外一个在我们的青少年常跟家人的互动，有些时候会有一些问题。所以这个家人的支持跟青少年跟家人之间的互动也是一个非常重要的环境的因素，而在年龄、在硬体，还有在我们所谓的这个社会环境、家人的支持、同侪的压力等等，这一些环境的因子呢，也是我们在协助这个青少年从一个青少年过渡到一个早期的成人，在这个转变之间呢，我们所要考量的这些环境性的因素。那以上是Reuben的回答。All right, I think Reuben, that will be all of the answer. So we still have a couple minutes because now it's the 6 minutes to 11. So I don't know any of our colleagues or even our invited speaker, you also have other questions for Reuben that I would like to help you to translate into Mandarin to help our Taiwanese audience understanding. Anyone has a further question regarding Reuben's speech? Or any issues regarding the transition from adolescence to early adulthood? Anyone? No? All right, so if there is no further question, so can we move? Oh, hold on. I found there are questions. There are two more. Please excuse me. So there's one more question that, oh, sorry, that's repeated. So that's the same. So I think we will be done of the questions. So at the end, Reuben, do you have any additional note that you want to deliver to our Taiwanese audience, since we still have 5 minutes left for this schedule?
Yeah, so thank you very much for the opportunity to speak for a few minutes. I think that, you know, we're in the midst of this study. This is only the first step of looking into these transitional ages. The next step would be to actually look at quantitative data. I'm very fortunate to be spending my sabbatical next year with Peter and Lily's group, and we will be looking at quantitative data to support the results that we're going to come up with this using their Fundus data as well in Taiwan. And Taiwan has been quite a remarkable partner in the area of disability evaluation. So this is not done. So we're working on the final results of this study. So this is the first time you're actually hearing this. This has not been shared with anybody yet. So this group is the first group to be hearing the concept and the preliminary results. What I'm hoping to accomplish is by next year when I go to Taiwan, is that we'll be able to present the final study and go on to the next step, which is looking at it from a quantitative big data standpoint to see if some of those questionnaires can in fact be sensitive to the changes that's happening during transitional ages. So thank you for the opportunity. I'm looking forward to seeing everyone in the fall of next year.
所以呢，Reuben在最后仅剩的这几分钟里面呢， 他补充了一下说，他刚所发表的这个演讲啊，只是他的研究里面的初步的。那当然，他现在就是在我们所谓的这个教授有一个留停的时间，可能是半年到1年。他利用这个时间呢，未来会跟我们的这个刘昌宏医师，还有我们廖华芳老师，他们呢，把他所做的这初步研究，把它更量化。因为台湾有非常多我们根据 ICF 系统所留下来的这些资料，然后他想把这些资料做量化之后，进一步呢把它扩展到后面来。所以他也希望说，这个明年啊，如果有这个可能性，他会到台湾来，把这个研究呢在量化之后，最后啊做了一个比较妥善的一个收尾。那这是他最后所补充的。那同时也谢谢大家。Okay, thanks, Reuben. I think we really catch up our time. So thanks again for sharing the information with us, and we hope to see you again next year, very soon in the future. Thank you. 也谢谢大家的听讲。那我想我们把这个时间呢交给我们下一位讲者，由我们的季文洲老师，那他来介绍我们另外一位讲者。谢谢大家。
谢谢 Reuben 戴辅志座长替我们的讲解。那接下来邀请我们第3个 session 的座长季文洲老师来介绍我们第3位讲者，请大家稍后。待会会后记得还有签退的部分哈，要记得在12点到1点之间要进行签退，我们才能够帮忙申请积分。那目前我们在调整一下镜头，请稍后。讲者的镜头。那各位与会人员，如果有任何问题呢，都可以从聊天室上面，我们有 Slido 的连接，可以把相关的问题在 Slido 上面去做提问。好，那我们进入第3个 session 的介绍。那我们请季文洲老师。
就是有关于那个Dr. Bickenbach. Oh, I can remove that?
Yes.
Really? Okay, thank you. It's 这个 section 的很高兴可以去来介绍这个那个 Bickenbach。Dr. Bickenbach， 他是我的一个非常好的朋友。那个他破天荒的，就是让我来这个参加这个研讨会。现在事实上是他那边的早上4、5点所以我非常感谢他。那这个题目其实有关于功能跟失能也就是说，其实功能跟失能现在是一个非常重要的议题那经过了这10年的发展未来会变成什么样子其实我们都不知道。所以我们请到那个 Dr. Bickenbach 来帮我们阐述这一部分的那个话题。那Bickenbach 他现在是在那个 Lucerne University 担任教授，然后他其实也是 ICF 跟WHO DOS 2.0的 WHODOS 2.0的那个 editor。那所以any question? Anybody can hear me?
Yes.
Okay, good. 那个，所以那他同时也在ICF 一个叫做Family of International Classification 里面呢担任那个工作，所以他对于 ICF 是非常非常那个了解的Now I start to speak in English. Functioning and disability is more and more important health issue around the world. It's an important time for the development of this topic. To be a scientist or to be art, what will it going in the future? So it's my honor to introduce my good friend, Dr. Bickenbach, to share this topic. Actually, it's 4 a.m., I guess, now in where he is. Professor Bickenbach is in University of Lucerne. He was one of the editor of ICF and Who Does 2.0, and still work for that now. He is also work in ICF research branch in Family of International Classification as Swiss Project Research Center. His topic is ICF and the emergency of human function science. Let's welcome Jerome.
Thank you, Danny. I'm in California, so there's no problem.
Really?
Hello, this is Jerome Bickenbach. I am speaking to you from Nutteville, Switzerland, and the University of Lucerne. And I must say that I'm very honored to be here today to talk about ICF and the emergence of human functioning science. I have to say that I'm very unhappy that I'm not there in person to see my old friends, Danny and Lily and others. It is a shame, but we're all living under these circumstances, and we have to do the best we can. So, although I would very much like to be there in person to see your reactions, and I will be obviously there later in virtual person to answer questions and whatnot, but first I want to give you this introduction to something which I think is extremely important, that is human functioning science, and how WHO's International Classification of Functioning Disability and Health has led over the past 20 years into what I will hope to convince you is a revolution, a paradigm shift in how we understand health, how we understand health sciences, and how we understand our role, both as clinicians and as public health specialists, with regard to the third health indicator, that is to say, functioning. So, thank you very much for this invitation, and let's get started. Let's start at the beginning and look at what it is that we should expect the remainder of the 21st century to look like. I'm sure all of you are fully aware of these facts, but let's start we can all agree on, because the future of healthcare, health and social policy with respect to the delivering of healthcare, public health, and indeed much of social policy with regard to people with ongoing health problems, and moreover the development of the sciences, of the health sciences in the next remaining of the century, are going to be dominated by two indisputable facts, one demographic and one epidemiological. And the demographic fact, which certainly in the East is a very prominent one, but in all countries of the world we're seeing versions of it, is population aging. And what that means, the good news is that people are living longer. People are living longer because of incredible advances in curative medicine, the success of health promotion and health prevention measures, and generally the improvement in social conditions and access to health care and access to those features in social policy that eliminate or mitigate risk factors for ill health. The irony, however, is that as people live longer, they live longer with more problems of health. Indeed, what we're seeing all around the world is a slow transition from acute health problems to chronic health problems. And that is the second of these dominating drivers of what we're seeing in the world, namely the epidemiological shifts. WHO has long identified these issues in the context of non-communicable diseases, in the prevalence of these diseases, from diabetes to dementia, from COPD to other forms of cancers and other non-communicable diseases, both mental and physical. With the increase of prevalence of long-term or chronic health problems, what we're finding is that people who are living longer with these conditions. These conditions are often well managed. Take high blood pressure, for example, a very common condition and in aging. Because these conditions are well managed, people are living longer, but they're living longer with these conditions. And what this means, once again, is people are living longer, but with more problems associated with their health conditions. Now, of course, we're talking in the COVID age, and some might argue, well, the COVID is an infectious disease, an acute respiratory condition. Well, what we're tracking here in Switzerland and other parts of the world is something which goes by various names. The WHO is now calling it long COVID conditions. And what these conditions are associated with the residue of recovery from the acute phase of COVID that turns out our suspicion is that these residual conditions are functioning problems, some mental, like the so-called mind fog, and some physical, that are also chronic. So even though we are, all of us, focused primarily these days on an infectious condition, a pandemic, this pandemic is what researchers are now calling a syndemic. That is to say, a condition which, though infectious, interacts with long-term chronic conditions and also with social conditions. And these interactions are actually prolonging the impact of an infectious disease to turn the residue, as I keep saying, into a chronic phenomena. This chronic phenomena also raises the burden of functioning problems across the population. So these are the facts. Here is just one example, somewhat out of date, I have to say, but an example of the kind of upward trends in population, with Japan leading the world in not only the steepness of this curve, but also the reach of it. There are various projections in Japan and China of individuals living well beyond the 100 mark, and that the prevalence of over 70, over 80 conditions will gradually increase. By 2050, one estimate is that in Japan and China, some 40 to 50% of the population will be over 65 years old. So as a social policy person myself, these kinds of trends indicate to me that there is going to be a revolutionary change across the board, from education to work and labor and other phenomena, accommodating this increasing prevalence of older age individuals. But in the health sector, what we're primarily concerned with is this phenomena of, once again, a higher incidence of problems that people have in their daily life associated with background chronic health conditions, or in the context of aging, multiple morbidities, so several conditions. The phenomena which is of most interest to me is not so much an individual living a long time with a single or 2 or 3 comorbidities with respect to the classic chronic conditions, but the phenomena which, in fact, as I age, I'm experiencing myself, namely a moderate decrease in vision, a moderate decrease in hearing, a mild or moderate decrease in mobility, all of these things which individually are moderate problems of functioning in various domains accumulate and, in fact, have an emergent feature to them that the combination of these conditions are not additive, but are synergetic in a way which makes the overall lived experience of one's health condition more burdensome, higher in functioning problems, in disabilities, than one would expect by adding these mild to moderate problems together. So what are the consequences for healthcare? Well, the obvious consequence is that we'll need more attention to chronicity, more attention to long-term conditions, chronic and multiple morbidities as people age. But as we have written several times, and as WHO in its Rehab 2030 initiative has made explicitly clear, what this means is that although curative medicine will always be with us, thank heavens, and that health promotion and health prevention strategies will dominate public health continually, these 3 health strategies, as they're called, will always be with us. But in the next 20 to 60 years, what we'll see is an increased reliance on rehabilitation. The WHO, Larco Cieza and colleagues have published about a year ago in Lancet a estimate of the total number of individuals currently who could, by virtue of their background health conditions, who could benefit from rehabilitation, and put that number at the ceiling level of 1.2 billion people worldwide who could benefit from rehabilitation. But that number is going to increase, and the reason that rehabilitation will take center stage in our understanding of healthcare is that rehabilitation is precisely the health strategy which, although it works hand in hand with prevention and cure and the other strategy, is primarily aiming to optimize the level of functioning that individuals have given the decrements or the decrease in intrinsic health capacity that an individual has by virtue of the background health conditions, and in interaction with those conditions to enhance what they can do in their lives, or performance in the ICF language. So what rehabilitation is precisely, if you like, what ICF is about. Rehabilitation is a strategy, a set of interventions that aims to deal with the existing level of health capacity that an individual has in mobility and cognition, in the sensory areas or other areas of the body, to deal with the existing level of intrinsic health capacity, and by heightening that level of capacity or by making environmental changes through assistive technology or other forms of environmental modification to enhance performance. The aim of rehabilitation, in short, is to make it possible for people to live the best life they can in light of unavoidable decreases in health capacity. That's why WHO and others have said that rehabilitation is the key health strategy of the 21st century. Our resources in the healthcare sector, in other sectors that involve rehabilitation, like labor, vocational rehabilitation, and other areas, will have to be realigned so that it is possible for people to have increased access to the rehabilitation services that they need. What this also shows for health scientists is the ICF notion of functioning is at the heart of the healthcare and public health agenda for the future. And why is that? Well, the reason that functioning is at the center of our concerns for looking forward is that because of the demographics, because of the epidemiology, what we're looking at is improving the lived experience of health. What we have said is that functioning is actually the third health indicator that we have to keep in mind. Standard epidemiology focuses on mortality and morbidity. Indeed, in the COVID area, what we have primarily focused our national attention on with respect to the pandemic is reducing mortality and reducing the burden on intensive care and on the hospital system, and trying to contain or limit morbidities. But as we're seeing with the drivers of population aging and chronic conditions, is we also have to focus on the indicator of functioning. Indeed, in the healthy aging environment, which much of our work is increasingly directed toward, healthy aging actually is a challenge to optimize performance in light of inevitable decline in health capacity. So in a sense, healthy aging, as the World Report on Health and Aging of the WHO has made very clear, healthy aging as an agenda, as a strategy, as a national objective is going to be one which has its roots in those interventions, social and health, that optimizes performance without taking into account a decline in health capacity, which, as one ages, inevitably will decline. This chart, which I've extracted and relabeled a bit from the World Report on Aging and Health, the 2015 report, shows exactly what's going on here, very simplistically. What we have is a functioning as the dominant indicator on the y-axis, and biological aging as a process on the x-axis. So as intrinsic capacity, as what the body and mind can do, what its intrinsic capacity is, declines inevitably. This is not a slope that can be altered. It can be modified in its steepness, but the direction is unmodifiable. What we can do, and what we should do, and what healthy aging as an agenda is about, is enhancing performance, ensuring that the top line, the blue line, does not track exactly with the capacity line. As intrinsic health capacity goes down, inevitably, performance will slope down, inevitably, but it doesn't have to slope down as steeply. The distance between intrinsic capacity and performance as one ages is the distance in optimization of functioning. It is our best attempts to increase and optimize a person's ability to do what they want to do in their lives, to keep active, and to achieve the objectives of healthy aging by optimizing performance. So what we're seeing in this kind of simplistic picture is the absolute centrality of the notion of functioning that is defined and characterized in the model of functioning in the ICF, the absolute centrality of that notion for aging and for other population health issues. Well, that was the impact on healthcare and our understanding of what society's response is to chronic health conditions. But what I want to turn our attention to is the direction that this talk is aimed toward, namely looking to a future where the very understanding of health sciences itself is modified. Now, from this point on, what I am presenting to you is speculative, is a speculation. It is something that we are actively working on here at the University of Lucerne and other places in the world. But at this point, we're looking to the future, and this conference is an ideal place in which it is possible for me to be speculative, and that's what I want to do in the remaining a couple of slides. So what I mean by impact on health sciences of the notion of functioning is this. The ICF gave us an intuition which has its roots in absolute common sense, to my mind. An intuition that when you and I take off our lab coats and cease to be scientists, when you and I are interested in our health, we are not so much interested in diagnosis of our health problems. It's an interest to us, but it's not the focus as human beings of what matters to us about our health. What matters to us about our health is in part how long we live, but living a long time unable to do anything that we want to do is not really a good characterization of healthy aging or indeed well-being. What matters to us about our health is what we can do with our health, with our state of health. And that what we can do with our state of health is intuitively what the ICF notion of functioning captures. ICF captures, to my mind, what matters to us about our health, our state of health, what our lived experience of health is. These days I have knee arthritis, standard for a fellow of my age. So what matters to me about my health is the fact that now going downstairs is a very painful experience, and that maybe I should take some look at rehabilitation interventions to strengthen my capacity to walk and whatnot. But the fact that I have not great, but a modest medium, low to medium, I would say, disability in walking by virtue of knee arthritis means that my concern about my health is the fact that I have pain walking downstairs. Now, I'm not ignorant of the causes of that. I'm not ignorant of the possibilities of cure, such as they are, surgical interventions or whatever. But the point I'm trying to make at a very, very human, intuitive level is that functioning is not some exotic scientific notion. At bottom, functioning just means what we care about in our lives. Now, given the fact that because of the future that we have before us, what we care about in our lives is going to be more prominent on the health scene, we're going to have to readjust not only our social policies, not only our financing of healthcare systems, not only on how we train people in rehabilitation and provide the workforce that can handle that, not only in terms of the data that we collect with respect to health information systems, so that we collect not only information about mortality and morbidity, but we rigorously, standardly, in a comparable manner, collect data on functioning, which of course is what ICF as a classification makes possible. But we also have to keep in mind that we need to turn our understanding of this fundamental notion of functioning into a science that can perform through scientific rigor the kind of developments that we're interested in. Now, I have identified here on this slide 3 components of this ingredients of what might be called health science, functioning health sciences. And they are precisely what you would expect them to be. First of all, we're going to have to develop and finalize and develop the methodologies for functioning epidemiology. Classical epidemiology, for obvious reasons, completely justifiable, focused on morbidity and mortality. So much of classical, what I'm calling classical epidemiology, is looking at issues of premature mortality, looking at issues of compression of morbidity and other classical notions. And epidemiology focused its methodologies and its other techniques and its statistical backgrounds on those kinds of notions, on those indicators, those health indicators. Well, what we need are robust, sophisticated, statistically sound, functioning epidemiology. We want an epidemiology that can capture the notion of functioning in all of its components. In part, as always, the first step there is functioning information. And I've already mentioned that our key initial step here is to get a rigorous, consistent, and comparable data on functioning. And although that is a huge challenge, at this point I'm not going to speak to it because in many ways it seems to me that the basic components of the challenge of collecting functioning information, the basic strategies, the basic methodologies, I think have been solved. There are problems in implementation in national health systems, in health information systems. There is the inevitable shift in the paradigm shift, if you like, of ensuring that practitioners, sorry, of course someone phones me while I'm giving a talk. Practitioners respond to the need for collecting statistically sound information on functioning. Well, sorry about that, but this shows you the importance of turning off your phone when you're recording a lecture. So let me take up where I left off. The first step, of course, is getting us some health information and then using that health information in a consistent way. And as I was mentioning before the phone call, implementing that is still a challenge in high-resource countries and all around the world. So I'm not suggesting that is no longer an issue that we need to be concerned about, but I want to look forward to the future. So the steps in health science that I want to identify are, first of all, functioning epidemiology, which I have talked about, and routine standard reporting of functioning in all contexts. So those are hugely important steps in the development of the basic foundations for health science. Also important, but certainly not something I can speak to with great authority because I'm not a statistician, is the development of functioning-related statistical methodologies. And there are three that I will point to. There are three that we are developing here at Swiss Paraplegic Research and at the University of Lucerne, and I am tangentially involved in these because I'm not a statistically competent individual. But each of these in different ways I have used in research in productive kind of ways. The first is a functioning metric. And for those of you in the audience who are familiar with item response theory and rash modeling, the use of functioning information in the context of the development of a metric is turning out to be an incredibly productive application. For example, in the context of spinal cord injury, we have a SWISCI, which is a spinal cord injury survey. We also have INSCI, which is an international spinal cord injury survey. And the data from this, both surveys have a range of questions, of course, but they have a full range of functioning items. And by virtue of the data collected from those surveys, it is possible to construct, in the spinal cord context, a metric for measuring more precisely the levels of functioning in a summary manner for individuals. And this is, of course, an unbelievably powerful tool in research in the context of spinal cord injury, as it would be for any area. Just another application that is actually skipping a couple slides ahead, but it just comes to mind. I'm involved in the reform of disability assessment procedures in 7 Eastern European countries, all of whom are moving from a standard baremic approach to assessing disability for social services and for Social Security and cash benefits and whatnot. Disability assessment in the baremic sense is the approach where one maps directly disease severity or disease conditions or disease severity onto percentages of disability of the person. And we are well aware now that that approach, going directly from diagnosis to disability severity, disability levels, is completely without scientific foundation. And we are reforming or assisting countries in reforming along a Taiwanese model, I might add, where Taiwan here is the leader in the world in this, of using the WHO Disability Assessment Schedule, UDAS, as the basis for collecting information about functioning at the activities and participation level where disability exists. The body functions and body structures or impairment level is interesting input, but it is not disability by any stretch of the imagination, because disability exists in an environmental context, and that is measured through performance in activities and participation. That's standard ICF information, which Taiwan is fully aware of and implements. In these countries, we have put into effect Social Security disability assessment procedures using HUDAS, and by piloting the HUDAS on 2,000 or 3,000 individuals, we're able to generate for each country a functioning metric that allows them to more precisely identify percentages of disability in a robust, valid, and reliable manner unlike a baremic approach, which is completely speculative. Another tool, a statistical tool, is functioning trajectories, which are proving to be extremely useful, primarily in the aging area. A functioning trajectory is simply a path or a pattern over time in both the levels of capacity, so the intrinsic health capacity functioning, what in terms of the health condition a person has the capacity to do, and also in terms of performance. And these trajectories enable, as the chart from the World Report on Aging and Health suggests, and enables in individual cases or by health condition or by population, and enables people to project the future functioning requirements and potential interventions and supports that an individual as they age will need, and also to plan interventions, the rest of it. The last area of which I am almost totally ignorant, but is an enormously productive and exciting area, is novel data technologies, which are both at the level of data collection technologies, both through body-borne sensors and other kinds of data collection that directly collects information, both through biomarkers, but also through impairment sensors and whatnot, but using big data and machine learning to develop highly sophisticated functioning tools. So these are some of the kinds of developments, all of which the epidemiology, the standard reporting, and the statistical methodologies go into the foundational level for health science. Both of these, or all of these technologies, are going to have an impact on health and social policy. And as I have already spoken to how using psychometrically sound functioning data will have profound effects, and have already in many countries that have undergone reforms in how they assess disability for social policy purposes generally, or for health as well. And I had mentioned that most of our work is done in terms of the WHO Disability Assessment Schedule, or the HUDAS. At the individual level, HUDAS is spectacularly useful, not only because it has almost unbelievably high reliability and validity records, so to speak, and it's flexible and it's easy to use and it's fast, and as an individual questionnaire, it's we are finding it very, very useful. It's either can be done through self-report or clinically administered, and it comes in a 12-question or 36-question. Anyway, as a tool, which WHO, of course, developed, it is proving to be incredibly useful in the social policy context, not so much the health context, although most of the existing applications of HUDAS have been in health. Just a historical note, since I'm old and I have a history, HUDAS was actually developed before, or actually concurrently with, the development of ICF, because HUDAS was the primary deliverable in a very large American contract that WHO got, and ICF was actually developed simultaneously under the terms of that same contract. So in a sense, HUDAS is not an application of ICF, it is actually a co-production of ICF. But given that actually ICF informed HUDAS and HUDAS informed ICF historically, but as I say, HUDAS is an extraordinarily sound piece of work. But the important thing to keep in mind, and why HUDAS has the role it has in the social policy context, there are two features of HUDAS that are essential. It focuses on what disability is about. Disability is about activities and participation. It's not about impairments. So it's very important that HUDAS asks questions in the activity and participation level and domains, the so-called D domains of ICF. And because of that, it focuses on what actually is disability, namely problems people have in activities of daily living, in employment, and the full range of D items that all of you are well aware of. The second property of HUDAS that's essential is that it is a performance instrument. There initially, two decades ago, was some controversy about whether it was a capacity or a performance instrument, but in practice it is clear and statistically it becomes dead obvious that HUDAS is a performance instrument. What does that mean? It means that the information that HUDAS collects is information from, of course, the respondent here is the person with the conditions. The information is information about what the person actually does in their actual environment with facilitators, with barriers. So what that means is that HUDAS identifies the performance level or perspective or dimension of activities and participation. And that is the level of disability. If I had my way, I would define disability as performance level problems in activities and participation. The ICF defines it slightly differently, but I don't think it's very useful to include impairments under disability. At the population level, and I have only very tangential information about this. The Model Disability Survey was developed in the past 5 or 6 years as a population level survey based on ICF that collects both capacity information at the population level and performance information at the population level, allowing comparison between the two. Why is that important? Well, the difference between population capacity levels in some domain like mobility and population performance levels in a domain like mobility is the difference the environment makes. So at a population level for policy planning, it is possible by virtue of comparing the two levels to get a sense of the degree to which the environment is enabling. The challenge that ICF created, and which has always been an extremely difficult scientific and practical issue to resolve, is how can we estimate or even measure optimally the impact of a person's environment on their performance, given that environments are so diverse and so multidimensional, moving, as ICF folks will know, from the physical environment to the attitudinal environment, the products and human-built environment, to the social policy and economic and cultural environment. Given the complexity of what we're calling environmental factors, how is it ever possible to measure the impact, either as a barrier or as a facilitator? Well, one way to do it is indirectly, maybe the only way, possibly, to do it is indirectly by comparing information on capacity at a population level with information on performance. So the Model Disability Survey, which is a WHO product and has been used and validated in several countries, is the population psychometrically sound functioning data collection tool that makes it possible to input into epidemiology. Well, my last slide is about the topic of my talk, and I only have a couple of minutes to do it. What all this stuff is talking about in the end is really the development, the emerging development of what might be called human functioning science. Human functioning science would be the science of taking functioning seriously at the individual and population levels and developing the tools, the methodologies, the statistical tools, the data collection tools, the analytic tools, and the conceptual tools needed to have a full-blooded science out of functioning. It is a vision that we have here at the University of Lucerne, and we are engaged in defining the components and piecing it together. The features of human functioning science is that it's interdisciplinary, that it is intrinsically, and perhaps the most intrinsically interdisciplinary health science imaginable, because it reflects ICF's interactive and multidimensional model. As a reflection of the ICF model of functioning, it inevitably has to have input from different perspectives, from the biomedical perspective, from the clinical perspective, from the rehabilitation, and also from the environmental and personal factor perspective as well. So it's interdisciplinary in nature, but it's not just an accident of human functioning science. It is interdisciplinary by nature. As I like to say, human functioning science is interdisciplinary not because it is the icing on the cake. No, interdisciplinarity is the recipe for the cake, if that image, that metaphor makes any sense to you. Human functioning science is intrinsically about understanding the functioning experience at the person level, and primarily to show the bridge, show the link, show how health is related to individual well-being. At the societal level, it's also about understanding how implementing functioning, identifying and implementing the societal response to functioning needs creates the bridge between health in its broadest sense and societal welfare. Okay, sorry about the interruption. It was actually Alarco Cieza who phoned me from WHO, coincidentally, but it was an interruption nonetheless, and I hope that the lecture is successful, and thank you very much for the listening.
Okay, thank you, Jerome. Give us the very good speech. Well, I'm wondering who called you before what. Just kidding. And here are 3 questions from our audience. So let me talk to you one by one. The first one is, could you talk more about the utility of functioning policy making? This is the first question. Let me translate first. 那个听众有问一个问题哦，想要问一下那个Jerome 哦，就是说他请他来多解释一下那个功能性这些功能资料啊，怎么样用来做那个政策制定，再多说一点这样。Okay, it's your time.
Yeah, I will try to be brief. In the health area, probably the primary utility of functioning data is to determine whether health interventions are successful or not. We have long believed that healthcare, or at the public health level, public health interventions do good, make a difference. But in order to measure that difference, all we had was mortality. Is a person dying too soon? Or we count diseases. Does the population have fewer diseases before an intervention than after? What functioning allows us to do in the health sector is to say, we now have a way of measuring what improvements in health a health intervention achieves. I can go on, but I think that should be enough.
Okay. Thank you. I think that should be enough. Let me. Could you please?
Jerome 教授的回答是说，在这个功能性的这个数据跟资料方面呢，最好的功用其实也就是用来检视我们现有的一些公卫的健康政策是不是有效。那只是在过去传统里头，也许我们比较从致病率啦、死亡率来当做这些成效的指标。那现在我们可以用功能性的数据跟这些资讯来作为成效的指标。
Thank you. Okay, the second question is, do you think the functioning trajectory could be compared between countries, or would it be unique, vary with culture? This is the second question.
Well, I'm not a statistician. Oh yeah.
第二个问题问的是听众问的是说，功能轨迹是可以让各国之间有一个，是可以让各国互相比较吗？还是它会依照不同国家的文化而各自会有他们独特的功能轨迹 ？Please.
Okay. I'm not a statistician, so I can't give a sophisticated answer. Intuitively, a capacity trajectory is a trajectory of human beings. So the variation at the capacity level is completely comparable. You have different levels of risk factors and other environmental changes, but all of that affects capacity in a way which is comparable, if not identical, between populations. It's certainly comparable. At the performance level, since it's the environment that's doing the work, the environment at the performance level is making differences in the trajectory, you're going to have more variation. And what you need to do is compare those in a way which I intuit, but I don't have the capacity to explain. Smart people like Reuben can do that. What you can do is find ways of getting a common metric of environmental impact so that you can put the impact of each cultural situation on a similar scale. And I'm sure that can be done, although I don't have in my own mind examples of it being done.
教授的回答是说，他现在大概还没有办法想到一个很确切的例子哈，但是在他直觉的想法里头，在这个功能轨迹的方面，如果是有关于能力的部分的话呢，应该是可以互相比较的哈，因为它应该会是蛮共通的。那但是在表现的部分呢，因为表现会受到环境的影响，所以它有可能变异性会比较多。那但是也许我们可以做到的是，如果我们能够控制哈，或者是也许能够掌握某些环境的这个影响的变相哈，也许就能够让各国之间有一个比较合适互相比较的这个基准。
Thank you. The third question. Would you please talk more about the Model Disability Survey?
Well, if you noticed, I started off by saying this is not the one that I know much about. But the Model Disability Survey was developed by the WHO to answer requests from countries whether there was an ICF tool, an ICF survey, that could be used at the population level for a variety of social and health policy purposes. And it's intended to be a model survey in the sense that it can be divided into modules
that can be, you can use the whole set of modules or individual modules, and that these can be added to other population surveys in a way which captures different kinds of information. It is, from my understanding of the status of the Model Disability Survey, its validation has been fairly robust, and it is now being used in several countries. Pakistan comes to mind, maybe Ecuador, maybe once again Reuben or Veronica will know. But it is certainly something which in the next decade or so will, I would imagine, dominate the field, but we shall see.
Thank you.
那教授的回答是说，他其实不是完全清楚这个整个计划的细节哈。不过这个是一个世界卫生组织，他们在了解，就是说各个国家哈，如果是以这个比较的国家的层级来看，他们是不是有应用一些 ICF 的工具哈，在了解他们这个整个国家的一些这个身心障碍的状况或使用在一些政策的上面，所以他们想要知道说，如果收集了各国的一些这个有关于身障的一些模型哈，或者是他们所应用的一些工具，是不是能够把这些资讯也应用在其他的国家的这个也帮助其他国家的应用。那目前他所知道的是，目前这个计划应该是已经有一些蛮好的资料哈。那例如像这个巴基斯坦这个国家，可能就已经有在应用一些这个计划所获得的一些这个数据或资料。那也许其他的2位教授也会有一些这个方面的资讯。
Okay. Any other question about the Jerome speech or note or anything? No? I have a question.
I was going to ask Danny, how's your lovely daughter?
Oh, my daughter is good, but she's not here. Thank you. And you know, the world is changed by COVID-19 the past 2 years. We all see the situation. I would like to know, in your opinion, is that possible to change how we look about function because of COVID-19? Because, you know, for example, stay at home, probably not so healthy, right? You don't go outside, don't go, but in the COVID-19 period, that's normal. That have to, you know, to save your life, for public self. So it's like a normal things. So I'm not sure about the ICF coding or the structure will change because of the COVID-19. Or the COVID-19 just one event from the outside of the environment, just one event, just every other like nuclear bomb, something like that. Just one event of the world. So what is your opinion?
Yeah, well, I have two thoughts. One of which we have.
Translate.
Oh,
that's fine. 就是说那个我自己介绍，就是说因为那 COVID-19 已经影响到我们现在这个世界蛮多的。那 ICF 其实是在描述人类功能这个东西。那可是 COVID-19 这件事情会不会改变我们对功能的描述，或者是种种的看法？比如说我们之前待在家里面，其实不太健康的啦。但是可是 COVID-19 来的，比如说 lockdown， 这是一个被迫的事情，你必须保护全人类的健康，或是大家的健康。所以不晓得 ICF 的架构本身会不会被 COVID-19 所影响，或者这个 COVID-19 它只是环境中一个事件，就像是核子弹爆炸诸如此类的事情。Okay, thank you. Your turn.
Two thoughts. The first one I talked about in my talk, namely, what COVID has shown is that the distinction between infectious and non-communicable diseases should be really looked at again, because in the next decade, unless the pandemic discontinues forever, which we hope it doesn't, in the next decade, we will be looking at the chronic components of COVID. The phenomena of post-COVID or post-COVID conditions may turn out to create a chronic health problem of many dimensions to it. And we're going to have to understand COVID as actually a combination of infectious and chronic problems together, because they'll probably be interacting in interesting kinds of ways. So what COVID theoretically has shown us is perhaps to take a look at what we mean when we talk about infectious versus non-infectious or non-communicable diseases. The second thing is what you're referring to. What COVID has shown all of us is the unbelievable significance of environmental factors, because our lives have been changed, not for those who have COVID, obviously changed for intrinsic health reasons. They have an infection, they have consequences and sequelae. But for all of us, we understand that our lives are fundamentally rooted in the world in which we live, and lockdowns and mask requirements and all of the other things which we're all familiar with have created a context which is very different than it was before, but which has clear health consequences, or indeed have fundamentally changed our functioning in many, many ways. So what COVID, to my mind, has shown is the incredible significance to understand health, of understanding health in an environmental context. Health is an interaction between what's under the skin and what's outside in the world.
教授的回答是说，的确这个新冠肺炎的疫情是有很大的影响哈。那第一个的话就是说，虽然现在看起来整个新冠肺炎还是在一个比较急性的情况，但是终究随着这个疫情发展下去哈，我们可能会面临越来越多，就是说从新冠肺炎遗留下来整个慢性的情况。所以我们现在看到的不光是一个急性期的这个疾病的影响，将来应该还会有越来越多有关于这个慢性的新冠肺炎的这个后续的这个影响。那另外一个则是很大的影响，就是在环境因素的部分哈。那包括了我们每个人内在的这个情绪啦哈，或者是包括了整个生活上封城，它是一个很大的环境上面的这个改变哈。那所以这整个新冠疫情所带来的冲击，其实是带来了一个，就是说包括了我们身体的功能跟整个环境之间相互的这个影响，两个层面的影响都很巨大。
Thank you. Okay, we have like 5 more minutes. Any question? Or Jerome, do you have any message you want to deliver to us or to all the audience?
I have the feeling that people have heard enough from me.
Not really.
Just to thank you and thank the Taiwanese scientific community. The work, I mean, you can tell from all three of us that we've all recognized, appreciate, and very much honor the scientific sophistication and innovation in Taiwan. And we do, all of us look to you and your scientists and your implementers, not just in the ICF, but across the board. So we all thank you.
Thank you. Okay, so move to next stage.
那就非常感谢学者们精彩的演讲哈。那相信今天的学员大家都收获很多。那时间也到了中午的时间了，那我们就因为理事长今天刚好有事不在，那我们请我们的廖华芳常务理事帮我们做一个总结。那谢谢大家今天的参与。那会后要记得上线，去点我们的连结去做最后的签退，还有满意度的调查，这样才可以申请积分。谢谢。那就交给廖华芳常务理事。
On behalf of the Taiwan Society of ICF, I want to present our sincerely appreciation to 3 distinguished speakers, Taiwan ICF important facilitators, Jerome, Reuben, and Veronica. And I also want to thank all the participants. I believe you will also learn a lot about the new ICF knowledge as I did in the previous 3 hours. Hope we will meet together and collaborate again in the near future to facilitate the societal participation of people with special needs. Take care and bye-bye. Thank you very much for your participation. 谢谢大家的参与，我相信大家跟我一样，在今天都学到很多东西。希望我们大家一起努力，把 ICF 应用在我们的特殊需求者的身上，使他们的社会参与可以更提升。谢谢大家，保重，拜拜。
Bye bye.
Thank you.
拜拜。
Thank you.